Welcome, welcome, welcome. Hi there. My name's Kate Breslin, and I'm the president and CEO at the Schuyler Center for Analysis and Advocacy. And I can't tell you how excited I am about our fantastic panel today, exploring intersections and potential solutions related to child poverty and health. And so we have a fantastic panel. We have a great group of folks who are logging on, and we're just going to get started. I'll ask our panelists to turn your cameras back on, and we'll get going. So I'll start with a brief overview of New York's recently enacted Child Poverty Reduction Act. And then we'll introduce each of our panelists and ask them to say a few words about the work. And then we'll really engage in some conversation. And we welcome your questions using the Q&A feature on Zoom. And again, we're super excited. We have a fantastic panel. I'm only worried that we have so much. This could be a 3-day conference. And we have an hour and 15 minutes. So I'll start by just talking about New York's Child Poverty Reduction Act, which is legislation that commits New York State publicly to cutting child poverty in half over a decade with attention to racial equity, and requires a plan to reach this goal and regular assessment of progress toward the goal. The law was signed by our current governor, Governor Hochul, and it creates an expectation that our leaders across New York State will act with intention in good fiscal times and in challenging ones to shield our children from far-reaching and long-lasting harms poverty causes. New York State, a state with vast wealth and resources, has for too long allowed hundreds of thousands of children to endure the hardships of poverty in times of recession and in times of plenty. New York entered the pandemic with more than 700,000 children living in poverty, representing nearly 20% of all New York children. With that percentage a full 10 points higher for Black children and 7 for Latino children. Compared to the rest of the nation, New York children were more likely to live in poverty than in 32 other states. And throughout the nation, the burden falls disproportionately on communities of color. We've seen that public policy can work. During the pandemic, New York and other states had real support from the federal government to turn the tide on child poverty, and millions of children were lifted out of poverty. It worked, but it was temporary. For our children experiencing poverty, every day that New York fails to prioritize ending it matters to them. The American Academy of Pediatrics notes children who experience poverty, particularly during early life or for an extended period, are at risk of a host of adverse health and developmental outcomes throughout their life course. This has a detrimental impact on children and families, but on the viability of all of our communities. Reactive interventions in the out years through public benefits or interaction with criminal justice, those interventions are far more costly than meeting the needs now. So there should be no delay in tackling child poverty now. So the Child Poverty Reduction Act doesn't make direct investment in families. Instead, it provides us with the tools needed to reduce child poverty. That's a goal, a public commitment in law that New York will cut child poverty in half. Requires an annual public report of the effects that any adjustment or reduction by the director of the budget will have on child poverty, and establishes a Child Poverty Reduction Advisory Council to develop a plan. So Schuyler Center has embarked on a series of these conversations to explore some of the intersections around child poverty and different aspects of children's families and communities. So as I said earlier, I'm super excited. I'm going to introduce our panelists one by one in alphabetical order. And after I introduce each one, I'll ask that person to talk a bit about their connection to this issue. So first, Dr. Benard Dreyer is at the NYU Grossman School of Medicine and Bellevue Hospital Center. He's a general and development behavioral pediatrician who has spent his professional lifetime serving children and families experiencing poverty. A professor of pediatrics at NYU, he leads the Division of Developmental Behavioral Pediatrics and is director of pediatrics at Bellevue Hospital. He's a past president of the American Academy of Pediatrics and is currently serving as the AAP's medical director for policies. Dr. Dreyer served as a member of the committee that authored the National Academies of Sciences, Engineering, and Medicine Roadmap to Reducing Child Poverty, which we refer to a lot. So welcome, Dr. Dreyer.
I need to unmute myself. Thank you very much. And it's great to see such wonderful colleagues. You know, Omolara and I go way back among other colleagues here. So nice to see your smiling face. I have been involved in child poverty since around 2013, when I got the AAP to put on its strategic agenda. Sorry, I'm going to turn my phone off. To do something, decrease child poverty significantly, and I sort of ran on that as the issue that I mainly was telling people about at the ground level in the AAP. And when I became president, or first became acting president, I started to work on getting the AAP to do something about it. In 2016, when I was president, they finished writing, which I had a lot to do with, but I worked with others. The first policy statement on children in poverty and the concerns that the AAP had about it. From there, as you heard from Kate, I was very involved in a couple of years with the National Academy of Sciences, reducing child poverty in half. And I've been one of the co-editors of two supplements to academic pediatrics about child poverty in the United States, one in 2016 and one in 2021. So I was thrilled, as many of us were thrilled, in 2021 when the Biden administration reformed the child tax credit, which is really a misnomer. Their reform created a child allowance for everybody in this country. And as we probably know, it dropped child poverty rates about by 5% in 6 months. But sadly, it was not reinstated in January 2022. And so poverty rates went back up. And that's where we are. So one thing at the federal level, I would hope we would try to do is get the reform child tax credit reinstated at the federal level as things hopefully change in our federal government. But in the interim, we have a lot of work, as Kate said, in New York State, because, I'm always shocked about how high the child poverty rates and just general poverty rates are in New York State, which we think is a blue bubble that should be dealing with these things. But although there's a lot of talk, I've been yet disappointed that anything has happened. So I do think this group has a lot to work on regarding getting our state government to really do something about child poverty, especially. And I think it's going to be hard because I'm often disappointed by our state government, but it's up to us to advocate and push the agenda and the needle.
Thank you, and that's why hopefully we're all here.
Yeah.
I'd next like to introduce Dr. Jamila Michener from Cornell Center for Health Equity at Cornell University. She's an associate professor in the Department of Government at Cornell University. Her research focuses on poverty, racial inequality, public policy in the United States. Her recent book, Fragmented Democracy, Medicaid, Federalism, and Unequal Politics, examines how Medicaid, the nation's public health insurance program for people with low income, affects democratic citizenship. And many of you may have heard Dr. Michener on other podcasts or other presentations, and we're excited to have you. If you can talk a bit about what brings you to the work, that would be great.
Yeah, absolutely. So, in the kind of the most direct in a professional sense, I think what brings me to this work is the fact that I study it. And I, from the beginning, coming to graduate school, knew that I wanted my work to be focused on poverty and racial inequality. And as a political scientist, in particular, who focuses on public policy, what brings me to the work is a desire to see policy crafted in ways that are responsive to the needs of people who are economically marginal and vulnerable, and in particular to see policy crafted in ways that are informed by and responsive to those people and communities themselves, right? So the emphasis and focus of my work isn't just on passing policies that are going to be good for people who are living in or near poverty. That's what we want. But it's also on thinking about the process for getting there and making sure that that process involves recognizing and building and expanding the power and influence of those people themselves, the folks who have the most at stake and who are living through the experience of being near poverty. So that's like a kind of meta umbrella. I think the kind of more personal work that brings me to this is, and the thing that sparks from the time I started college, my initial interest in poverty. My freshman year of college, I took a course called the Sociology of Poverty. I've always cared about this. And it's because poverty has been a function of my own life experiences. My parents immigrated to this country from the Caribbean with very little. And I grew up in low-income neighborhoods in communities that were overwhelmingly disproportionately populated by Black and Latino families that were low income and that were struggling to survive. And I watched and have continued to watch my own family members, my own parents, right? I wrote a book about Medicaid, and as I wrapped up that book, I was managing my own mother's Medicaid case, and so on and so forth. So as a scholar, I think about these things from an empirical perspective, from a historical perspective, from a research-based perspective. But I also infuse that thinking with a very grounded sense of the realities of what's at stake for the ordinary people who are navigating these systems. And that's not something that's far away from me. It's something that continues to be very close. even as my life is now very different. And I'll just end by saying my work is multi-method. So I draw on qualitative and quantitative methods. And in particular, one of the benefits of me being a scholar that draws on qualitative methods is that I've continued to and continue to, in my research, in the course of conducting my research, be connected to people who are living in and near poverty. My research gives me an opportunity to talk to those people, to center their voices and their perspectives, and to do it through this mechanism of research and public scholarship. So that's a kind of, in a nutshell, a lot of what brings me to this work and what frames my approach to it.
Thank you. I'd like to now introduce Kristin Rivera, YPA-C, regional youth partner at Families Together in New York State. Kristin is a driven, ambitious leader who strives to eliminate barriers in recovery systems. Her passion stems from personal experience living with mental illness and facing difficulties in navigating mental health systems during her childhood and into adulthood. Kristin was the first in her family to pursue higher education, where she graduated from Binghamton University with degrees in psychology and sociocultural anthropology. Before joining Youth Power, Kristin had the privilege of working with young people and geriatric communities to assist in educating and empowering individuals on their road to recovery, using peer recovery programs, direct care management, and community-based services. We're so excited to have you, Kristin. And if you could say a few words about what brings you to the work, that would be fantastic.
Thank you, Kate, and hello, everyone. Such a pleasure to be here. As Kate mentioned, I do have what I would call lived expertise with navigating systems that deal with families and children receiving services within New York State. What brings me here today is to share a little bit about the experiences that families and young people have currently in the past, and possibly discuss what we can do to help better those experiences of families navigating systems, especially those who are enduring poverty and are interested in improving the welfare of their children and family as a whole. I hope that this discussion will be a great one, and I hope that our audience is very interactive when it comes to our Q&A towards the end. And also, as Kate mentioned, I do come with a little background of studying cultures from both a psychological background and then also studying cultures through an anthropological lens. So learning how to be more person-centered when trying to come up with solutions to things such as poverty, and how can we create best policies to reflect the needs and supports of families living in New York State. And again, I'm honored to be here, and I thank y'all so much. I'm looking forward to our discussion.
Thank you, Kristin. And finally, I'll introduce Dr. Omolara Thomas Uwemedimo, from the CEO of Strong Children Wellness. Dr. Uwemedimo has been a practicing pediatrician for the past 14 years in the United States and internationally in several countries across Latin America, Asia, and Sub-Saharan Africa. Her perspective on delivery of pediatric care is globally informed, innovative, and unconventional. Healthcare can be delivered effectively in non-healthcare settings in the community, and must consider not just the child and the disease, but the parents, the household, and the larger community. She has served as faculty at Columbia University Medical Center and Cohen Children's Medical Center, conducting research and training physicians in community-engaged pediatrics, social determinants of health, and care of global and immigrant populations. And I consider her a friend, and I'm happy to introduce her.
Hi, hello. I'm so excited to be here. Excited to see people who've known me in medical school before I even was a doctor, Dr. Dreyer. So awesome to be here. What brings me to the work, I would say, is even before I was born, my mother had to go on food stamps as when she was on bed rest with me. She was a nurse who emigrated from Nigeria and was on bed rest for her whole entire pregnancy. And just remembering kind of how that was the bridge to be able to help both me come out healthy, but also to ensure that she was able to get back to work and continue to provide for her growing family. And so, you know, personally, I feel a connection to this work in particular, but also from a professional standpoint, in terms of my connection to global health, which is the way I was introduced into thinking about child poverty and injustice, and really seeing extreme levels of poverty, but also seeing very innovative ways that poverty was being addressed through healthcare, and healthcare being this safe place where we knew children would come into, and that at that point, I like to say it's the container where we can grab the whole family and really be able to address the multitude of issues. And so my work is primarily thinking about what are the ways that we can identify medically complex, psychosocially complex children, but also children who are living in poverty, and utilize the healthcare space as an opportunity to address all of the family needs. Strong Children Wellness, which I created after my academic career, is really about turning the tables on healthcare and bringing primary care, mental health into community-based settings where children and families are most engaged in their communities, specifically social service agencies or behavioral health agencies. To date, we have about 1,100 children and about a little under 200 children that we're caring for over the past 3 years. And under that model, what's really interesting is that we're able to address their primary care needs, but we're also able to address mental health needs and anything from food, immigration, housing, employment, and all of those things in one setting for both the child and caregiver. So I'm really excited to talk about this. Also really excited, hopefully, about the reintroduction of the Early Child Poverty Act by Rashida Tlaib and Representative Omar. So, you know, just thankful for the opportunity to be able to be here and discuss this further.
All right. Thank you all so much. I think we'll start with I have a couple of questions to get us going. And I'll start with you, Kristin. I think we'll just use first names, with all due respect. Kristin, from your experience, in what ways does poverty affect the wellness of families and young people?
Great question. So another part about my experience is I would consider myself a product of poverty and the public welfare system. Being a child, teenager, and young adult whose family was dependent on services and supports through systems such as Medicaid and other public welfare systems that helped our family. Unfortunately, although these can be beneficial, sometimes the family dynamic and the wellness of a family and children can be negatively impacted. Some of these impacts include having adult responsibilities as a young person. So, for example, myself having to work as a teenager, right? Having to help provide, be a supportive sibling while my parents are out trying to get higher paying jobs and trying to support the family. Their absence in that sense reflects on the children, right? And like I mentioned, that adds adult responsibilities to children and teenagers who then may have to learn their own coping skills and also navigate life through their lens as a new person to this world, right? Who does not understand what a system is, who does not understand why mom and dad have to work so much, right? And do not understand why sometimes their own mental health needs and their own joy may be put to the side when it comes to trying to make sure that there's food on the table, right? Make sure that there's clothing, make sure that bills are paid, so you have lighting and water. Fortunately, now there are other systems that can support that, right, for people in poverty. However, when it comes to wellness, those systems may not be in support of making sure that parents and children are okay, right, are okay mentally, are okay emotionally, and are okay socially. Again, having to have extra responsibilities as a child, and essentially extra responsibilities as a parent trying to support a family throughout poverty can hurt the wellness. So I'm hoping that moving forward, there'll be more supports for the wellness dynamic of a family, right? Including mental health supports, including healthy outlets for children and parents to get support from other people who have similar experiences. And then with that, I believe we can then better the wellness of family dynamics so that they're not always feeling as though they're in survival mode.
Thank you for drawing attention to sort of that component of wellness, and that, you know, our systems, our government systems tend to operate in these silos, and you called out, you know, health and wellness, and families need different kinds of, you know, different kinds of support. And we're still not there yet with really having an integrated system that focuses on family needs or community needs. So thank you. Benard, can you speak a bit about how child poverty shows up in your practice, what you see, what you've observed, and talk about the connections to how child poverty shows up and the connections to health? You're on mute.
I'm trying to be quiet most of the time, but I have to turn myself on at the appropriate moment. So to me, the major impact, although there are many health impacts, but the major impact of poverty on children's well-being, I would say, is their lack of progress. They're often not ready to start school. And often when they start school, they're already 2 grades behind wealthier. I wouldn't say wealthier, just middle class families. And by the 3rd grade, they often are so behind that it's hard for them to catch up. Now, it's not impossible to catch up. And that's one of the things we have to talk about. But early childhood poverty, because families are not either given the economic resources to enrich the child, the lives of their children, or their stress is so high because everything is piled upon them. And I always, this sounds like it may be a joke, but it's not a joke. It's hard to read Goodnight Moon when you're concerned about paying the rent. So we need to help families with their stress, the stress caused by poverty, and we need to help children and families to provide increased resources so that children should be ready to start school and also successful as they go through the primary grades, etc. So there are a number of programs in pediatric primary care. Many people here may know about something called 3-2-1 Impact, which H&H, as well as the Robin Hood Foundation, has funded. Right now, it's only in 3 of the clinics in hospitals, but it needs to be in every one of them. And what that 3-2-1 Impact provides is screening for maternal depression and therapy for maternal depression in early infancy, as well as Reach Out and Read, as well as something called the Video Interaction Project, which provides, better parenting opportunities to families. And then, of course, Healthy Steps, which is often the backbone of any of these programs. So there's a lot that we can do in primary care pediatrics if we got the funding from the state. So I think Omolara and I have been on the value-based payment, treadmill, I would say. And so we have not really turned this around, but the state could provide every clinic, but also every practice that takes care of poor kids with the resources to provide these kinds of programs, and that would make a big difference. Of course, the other big issue is, of course, something we need to knock on Governor Hochul's door, which is to get a state level a reformed child tax credit, or whatever we want to call it here, to really make a difference in the amount of money that families have. There are also nutrition issues. I mean, most of our families, poor families, run out of SNAP benefits about halfway through the month. Those benefits should be increased, and the level of poverty should be increased to at least 200% of poverty. So there are issues in nutrition. We also deal with racism and bias, which impacts children of color, but often those children of color are also poor. So there's a real overlap there. And we talk a lot about the preschool to prison pipeline, which is real in my experience. And so we need to advocate for doing something about that as well. I'm going to stop at the moment.
Well, thank you. I mean, there are a few things pieces I just want to call out and highlight. I think it's important to remember, as you started, that child poverty isn't determinative in the sense that it means a person is doomed. And I think sometimes when we're talking about it, we do want to call out that it can be harmful, but we want to also remember that it doesn't, it's not finally determinative. And I want to thank you for calling that out. And then sort of the connections between health and learning, and similar to some of Kristin's themes, that there are a whole host of things across a spectrum. There's nutrition, stress, and we need to be meeting families' needs in a variety of ways that don't always align with our government and payment silos. And then I'm glad you talked about sort of the evidence-based, family-oriented interventions, that we really need to think about families and communities, not only children, because they're not in isolation. And then I think those of us on the Child Poverty Reduction Advisory Council would agree that we need, one of the things is strengthening our child tax credit or getting to a child allowance. You're not going to solve child poverty without an investment.
Yeah, and two things I didn't mention. One are the specific issues of immigrant children, which I'm not going to talk about now, but perhaps we can talk about immigrant children, since they have specific issues. And I think our programs also need to be patient-friendly and respectful of families. Not so. The most effective programs are those that make families feel good about what they're doing rather than criticize them about what they're doing. So I do appreciate your comment there, because often in the old days especially, but even now, a lot of programs that are supposedly helping children are sort of blaming the victim. And we don't want to blame the victim. We want to help families in a very nurturing and positive way.
And I also, you mentioned racism and also, immigrants. And so Jamila, your work has focused on health and equity. Can you speak to some of the equity considerations that come into play with regard to health and health access, especially for families experiencing poverty? You're on mute.
Sorry, guess we're all going to do that. Absolutely. I think that the kind of general statistical patterns are clear to anyone who is paying attention to poverty, which is that families of color, Black, Latinx, Indigenous families are more likely to be they're disproportionately likely to experience poverty at any given stage in the life course, but also the likelihood of at some point living in or near poverty is much higher, as specifically, and I think most disproportionately for Black Americans and Native Indigenous Americans, but also for Latino Americans. So we know that the numbers tell us that there are disproportionalities. I think one of the things that's important to consider is like what's underlying those numbers. So sometimes we hear that, and without any additional contextualization and without an attention to kind of structural realities, one conclusion that people can draw when they hear these racial disparities is, well, what's going on in these communities, right? What's wrong with these groups of people or with these communities? What are they doing to make them more vulnerable to poverty? And so I think the first thing I would say is, when it comes to understanding racial inequities and poverty, it's really important to focus on the underlying root causes, which are structural. They're not about what people are doing or failing to do. They're not about their behavior or choices, and they're not about their culture. Certainly in the context of very constraining structures, people are making choices, right? And all sorts of people make bad choices and decisions. People who are living in poverty, people who are middle class, people who are uber wealthy, right? That is a part of the human condition. But it is because of the way that our policies and our social welfare systems are structured that is what explains why when people living in or near poverty make decisions, whether good or bad, those decisions are more likely to lead them to that outcome, to living in poverty. So just keeping that kind of structural focus in mind, and then thinking about what that means and how it manifests in people's daily lives. And so both how it manifests in our policy and how it manifests in people's daily lives. And so often there are policy interventions or policies that we pass and we don't think about. If we don't think about racial equity, it's easy to sort of inadvertently, disproportionately harm people of color. If we think about, for example, work reporting requirements for supplemental nutrition assistance programs or for Medicaid, those actually tend to be pretty popular. People like the idea of having to work to get government benefits. I'm not a huge fan of it, but people like it, right? And one of the things that we often don't think about is who's going to be disproportionately affected by those work reporting requirements? Well, we know there's a substantial amount of research to suggest that there's discrimination in the low-wage labor market, racial discrimination in the low-wage labor market. So once we tie labor market outcomes to your access to healthcare or your access to nutrition benefits, food benefits, now we're amplifying the racial discrimination in the labor market and carrying it into these other areas. So just creating more and more, proliferating the areas where people living in poverty who are people of color are going to be more likely to be affected. Similarly, we know that you're more likely to have contact with and negative experiences with the criminal legal system as a Black American or as a Latino American. And that contact makes it more difficult for you to find a job. So now your Medicaid is contingent on finding a job, which, right? And so I give these examples to say that these arenas are all integrated. And so when we have racial discrimination in one arena, the labor market, or, you know, the criminal legal system, and we know that we have that there, there's ample evidence to suggest it, policies can carry over those biases into other areas. And that's just an example to show some of the ways that the inequities that extend and expand and deepen poverty can be built into our policies. And a policy can seem like it has nothing to do with racial inequity or racism on its face. And then when we look at the disproportionalities and who is affected and how, we start to see all the ways that these policies affect different communities in different ways. I guess the last thing I would say, because I don't want to take up too much time, is that it's also important to consider the ways that people are experiencing these things on the ground. So I just wrapped up a 3-year study where we interviewed over 600 Medicaid, SNAP, and WIC beneficiaries about their experiences with those programs. And it was funded by the Robert Wood Johnson Foundation, and the focus was on how people's experiences with those programs affected their ability to be healthy, and how those experiences shaped outcomes related to health equity. And what we found is that many of the people of color that we sat down and had in-depth interviews with had experiences, direct experiences that they could point to about how they were treated differently, or about how what was going on in their life was different than what they knew was happening in other areas, right? And it might be differential access. You know, you live in a city and there are lots of, there's a concentration of Medicaid beneficiaries there, but doctors put a limit on how many, what proportion of patients they'll take who are on Medicaid, right? So many doctors' offices will have signs not accepting Medicaid patients, right? And in many times those offices are in places where the people most in need of those benefits are people of color. And so now you might have access to the resource, like technically you're enrolled in Medicaid, but you might not actually be able to get the care that you need. And that's not because the doctor's offices are trying to be mean or selfish. It's because Medicaid is reimbursed at a dramatically lower rate than other kinds of payers, right? And that's another example of, you know, Medicaid reimbursement rates on the surface has nothing to do with racism. But when we look at who gets affected by those low reimbursement rates and how, it turns out that it's perpetuating racial inequalities, not only in an aggregate sense when we look at the numbers, but in a very material sense when we look at the texture of people's experiences and in their everyday lives. So I will stop there.
Thank you. That was a really robust answer, and it, you know, I think it just highlights that the role that racism plays too, sort of across all of the things that we're talking about and all of the systems. Omolara, could you speak a bit about how you worked intentionally to integrate health and connections to other systems for families? I feel like that's something that keeps coming up, that it's not just one thing ever, you know, it's especially with poverty, that it's a whole bunch of things. And so can you talk about your work to intentionally integrate across systems?
Yeah, I think I'm just reverberating after Jamila. That's awesome.
Yeah, bring it. And feel free to reflect on that as
yes,
well.
I think, you know, it just reiterated a lot of the things that I think that our families go through. And, you know, one of the big things that has informed why my co-founders and I created Strong Children Wellness in the way that we did was because of the fact that a lot of times what we're seeing often are these cracks where we've centered healthcare around physical health and have not been expansive enough to really think and know that healthcare is even though we put it in these silos, is not physical, it is mental, it is social, all of that is health. And so ultimately, with that expansive knowledge, it disrupts, right, what the healthcare system looks like and also what they're willing to pay for, even though the evidence already shows that clinical care is only 20% in terms of the contribution to health outcomes. And so because of that, our goal was to say to ourselves, we're doing great work with what we have inside of a traditional healthcare system, but the real work that is going to change the lives of our families and their ability to access health, utilize it, and get quality health outcomes is actually happening way outside of these four walls in the clinic. And so our goal was to say, how can we actually just bring clinical care into those settings to make it easier for families, to also bypass a lot of the mistrust that is rightfully so, that happens within healthcare systems, and being able to leverage providing clinical care and leverage the buy-in and credibility that many community-based organizations have painstakingly created. Our first iteration of that, and what I think is a model that I'm hoping will be replicated, it was working with an organization here in Queens called Schuyler Center of New York, which provided behavioral health, social service, youth development, early childhood education, and bringing an actual medical facility within there. So right next door, having access to early childhood mental health, right next door, having access to JobNet for adolescents, and that integrated care coordinator helping us to make sure that once we screened and had the fullness of screening, not just what you go in and get your medical problems and screen for that, but is there an immigration problem? Is there an employment issue? Is there issues with your housing? When we screen robustly, being able to have that integrated care coordinator to be able to allow for us to make sure that that person not only got referred, but was navigated and closed that loop. One of the things that I think has been important and definitely feeds into this issue around Medicaid has been the idea that navigation is not adjunct. It has to be a core piece of how we deliver healthcare, and specifically social care navigation, not just subspecialty physical health providers, but getting families into public housing programs, getting families connected to supplemental nutrition, getting families access to legal support, specifically for our undocumented immigrant families. And so that is the core of what we are trying to do. We have a system which every family has access to a navigator that is not reimbursed. And we've been able to luckily subsidize that through other lines that we have with either our kids who receive mental health care or who receive intensive care management. This is not the way that it should be. And I think a lot of what we are trying to do, especially with our advocacy, is trying to make sure how can we now help people understand the real appearance of what health should look like and what is necessary to truly provide healthcare for impoverished individuals, as well as just in general, every child, whether you have, a very resourced family versus an under-resourced family, should have access to an individual who can really support their family to make sure that they're getting to where they need to get to.
So I want to just ask you, Omolara, I know you have a hard stop at 2, and we bumped this to go to 2:15. So I just want to ask you one more question so we catch you that follows on that, which is as we start to pivot toward the conversation about solutions. And so you build a practice that tries to do some of this integration, recognizing, families are whole families, and they have multiple needs and multiple interests. So what are the system kind of changes that you think could facilitate ways of addressing families' needs more holistically?
Yeah. So I think the first one I alluded to was being able to have payers expand, and it's not a huge lift, but expanding the Medicaid reimbursement and increasing that to include core navigation, social navigation that will be available for all patients. So rather than not having any billing codes or anything that is able to be used for social navigation is an injustice. I think the other piece that is going to be around systems is starting to help healthcare organizations think a little broader outside of their ecosystem, right? Outside of the ivory tower. And what I mean by that is recognizing who is actually doing this work already and probably doing it a lot better and connecting a lot better with the families in the community. So for example, yes, we could have stayed in our healthcare space and provided mental health services, but a lot of times what we were finding was culturally responsive and linguistically responsive health services were being provided by this wonderful community-based organization. And so instead of so you wonder about, should I take these resources to duplicate that, or should I take these resources to enhance what this organization has already been able to do? And so I think a huge piece of this is going to be community-based partnerships, but really deep, not only I'm able to refer to you, but I'm a backbone institution who can actually provide funding and financing into your work, which was something that happened with my former institution as we were developing our partnership to actually put funds directly to them to support that larger amount of families who would be accessing their resources. The last thing that I think is going to be extremely important is around the training of our healthcare individuals and professionals. I think in particular, there is a lot of talk around social determinants of health, a lot of talk around, health equity. I think that we have to move towards health justice and really helping people start to break down these silos and say to them and understand what does it look like to take care of families and assess for their unmet social needs, but also giving them the background on how do you do follow-up, how do you do care coordination, how do you work rather than referring to a social worker, how do you work collaboratively with the social worker in order to get the best needs met. And so I'd like to talk about how do we instrument care conferencing and family conferencing, and having those skills is going to be extremely important in terms of just making sure not only access and utilization, but the quality of services that people feel once they get to a healthcare practitioner are robust, are sound, and are respectful for those families.
Thank you. This makes me think of something, Kristin, you had mentioned about trust and, the importance of trust in providers and in community organizations. Can you give us your thoughts about how can we all build trust between families and providers?
Yes, trust is a very important value when it comes to not only wellness, but also solutions, right? A lot of times families and children who do not understand trust from either generational trauma or from a continuous disappointments, right, of empty promises not being upkept, either from their providers, from the systems that they're using, and even as from government as a larger system, right? So one way we can rebuild trust is, one, being person-centered, meeting people where they're at, right? Not placing expectations that they have all the answers already and that they're choosing not to follow paths that may be assumed to be best for them. Some ways to do this is having feedback sessions, right? Opening conversations and creating a safe environment where children and families can talk about their experiences without judgment and can talk about their experiences with other people who understand what they're going through. One thing about the field I'm in right now, the peer workforce, everybody has that experience of navigating a system either as a child or as a parent with a child using services. And In our role currently, we do that, right? Like as a peer, a youth peer advocate, we create those safe spaces to hear the experiences of teenagers and children, to hear experiences of parents, right? And the disappointments that they faced historically and the fears that they have moving forward, right? The fear of, if they are being honest about their experiences, are they then going to be hurt, right? Are they going to lose a service? Are they going to hurt their family dynamic? Are they going to hurt the relationship they have with a provider that they struggled so hard to get, right? As we're talking about accessing services and having the education of how to navigate these systems, just re-amplifying that to them in a safe space without the fear of retaliation. And then of course, another thing, as everyone here seems to be on the same, agreement with, is having a centralized location where these things can happen. Having a place in the community where these conversations can take place frequently, and where that feedback can then be provided to the systems that are creating policies that impact the children and families utilizing those services. And also, aside from a systems base, just understanding that not every family and not every child has the supports that are assumed upon them, right? Not every family knows what trust is, right? Not every family knows that their voice is important when it comes to the services they're getting, and that they can provide input on the policies and procedures that are impacting them today and also long term. I think another thing is possibly having more immediate effects, right? As we see that policies take a long time to be implemented, funding takes a long time to be acquired, and also the fact that there is a little instability when it comes to the people representing families. So just trying to implement more stability in an unstable culture, right, such as poverty, I think that will help to rebuild trust within the family, but also between families and the services that they are receiving.
Thank you. Thank you. Do any of you have kind of questions for each other or things you'd like to follow up on? I don't want to monopolize. Things you want to pop in?
I don't know who this is a question for, so I'll admit that up front, but we've all talked about getting the state to provide money to families through some sort of reformed child tax credit or child allowance. And I don't see any activity at the state level. So if somebody is seeing that, including Kate or anybody here, I'd like to know who to scream at.
Well, I can say last year there was legislation that corrected an error in New York's child tax credit. And so until last year, or until this year, children under 4 were ineligible for New York's child.
Yes, yeah, I remember that.
And an error has been corrected, and children under 4 are now eligible for New York child tax credit. And the Urban Institute has run data that suggests that will have a measurable impact on child poverty. So there are a lot of us, including I'm on the Child Poverty Reduction Advisory Council. They're including on the Tax Policy Committee, and we are very much looking at the New York State's child tax credit, which immigrant families are able to access.
Yes, that's another positive.
Child tax credit, and we're looking at the earned income tax credit. There are proposals to combine. There are a lot of proposals out there about how we could strengthen and expand those tax credits. I think kind of goes without saying that one way to address poverty is by getting money into people's pockets.
Yes, yes.
That won't solve, especially, I think it will, we could make the argument and, based on data that it would mitigate the negative health implications, that actually raising incomes would have a beneficial effect in a whole array of areas, inclusive of reducing child poverty. And there are proposals coming through the Child Poverty Reduction Advisory Council. And Schuyler Center for sure are working with many partners around the state to really try and advance those and make the case for those. There are also several pilots only, but to try and to look at pilots to do child allowances, which are, there are all different models out there, but ways of getting money into the hands of, for example, new parents, families with new babies and others. I think, many of those are being studied, and I think we all should be advancing that. It's a pretty clear way of reducing child poverty.
Can I make a related comment, which is the child allowance or tax credit or what have you, these sort of larger policies that we want to see at the state level. I mean, the national level seems to be a non-possibility. But also along the way, I think we've mentioned like a fair number of policies that would be helpful. Sometimes those policies are administrative, like how we organize agencies or how we organize services or benefits. Sometimes they're legislative, how we redistribute, monetary resources directly or indirectly. And one question that always emerges for me, and this is probably because I'm a political scientist by training, when I hear these conversations is how do we get from here to there? Because it's not going to happen out of the kindness of anyone's heart, right? And someone in the Q&A asked a question about cost and making the case about long-term savings,
Yeah.
And I think it's a great question, but really it's a question I think that that presupposes that there's an argument that you could make that would be compelling enough that would get us this. Like if you show that it's fiscally responsible or savvy, if you show the evidence of, there's so much evidence that we have now, given what happened with the expanded tax credit under the during the COVID-19 pandemic, we have more evidence than we've ever had about the range of positive effects of something like a child tax credit or an allowance. And the idea that if we have enough evidence or if we make arguments about the costs and benefits in a way that is compelling enough, we can get this is an idea that I unfortunately often when I'm teaching have to disabuse my students of, because it's not the way that policy processes work. And I guess there's a word that we haven't really named yet that I want to just put out there for any of us to think about, or for those who are listening or any of us on the panel to consider, and that is power. That is how we get from here to there, by the people who have the most at stake here, the people who need that child tax credit or benefit, the people who are experiencing the downsides of these programs and policies. When and if they have power, real power to influence policy processes, that's when we'll see something different. And in the absence of that, we can make marginal progress, right, through advocacy that happens, among kind of people who are in the professional advocacy space, and through advocacy that happens among researchers like myself, or among practitioners like Dr. Dreyer, and so on and so forth. But I guess I would venture to say that until and unless we think about ways of building robust, strong, and consistent power among the populations with the most at stake, we're not going to see the most transformative policy changes or the most transformative outcomes in the communities and populations of interest. So I just wanted to put power on the table as something that we should really be grappling with. And I know it's a big, hard, abstract thing, but it's also in a very concrete way, one of the most pivotal pieces of this puzzle.
For sure. Thank you. That's perfect. And I think there's a little bit of a circle here too, because at least at the moment in our society, in many societies, those who have the power are those with the resources, right? So there's a lot to do, right? To switch that around, both in terms of where the resources are and where the power is.
Yeah, absolutely.
Well, I think that's a perfect way to close us out. Thank you for that. I think that it's probably the most important conversation we need to have is about power and making sure that the people who should have the power have the power. So
Yeah. I would just add, I completely agree with Jamila, by the way, but as a cynic about all of this stuff, I'm not seeing a clear pathway to give poor people or minoritized families the power that they need. And I also wonder whether magically, if they had the power, would this be what they would focus on? So we have to respect that they may have other things other than getting a reformed child tax credit.
For
But
sure.
yeah, so anyway, but it's a great point, Jamila.
And
Yeah, the only
Kristin,
thing, go ahead, Kristin. Sorry, I didn't see
were you
that.
trying to get in, Kristin?
Yes. I wanted to feed off of both Jamila and Benard here. So when we're talking about this power discussion, right? One way that in our practices here at Families Together in New York State and Youth Power, and especially the mission of the peer movement, is to gain power by empowering the individual, right? And there are, family peer advocates are there to help parents, right, get what they need in order to succeed regarding their own wellness, and helping them have tools so that they themselves can learn how to make healthy choices and feel confident in those decisions that they're making. And that has been going on for years. And it's been effective to the point where now we are connected with these state systems that are directly creating policies for such as mental health services, child welfare services, Department of Health Services, right, regarding Medicaid billing and things like that. So there is a power to empowering communities. However, it has to be person-centered, right? Not every adult, not every child is going to approach empowerment and approach advocacy in the same way that we may do, right, as very educated people with experience doing research, right, with experience of having those this understanding that there is more answers out there, right? There is knowledge out there. There are more resources out there. And this kind of goes back to an earlier conversation of needing to educate the community, right? And that's part of empowerment as well. When people have those resources to learn that there are supports out there for them, that there are other people who have gone through similar things and have come out wonderful, right? Have come out strong advocates, have come out getting into policy and working within these state systems that they once were dependent on. That is where the power can then grow, right? And we as a community and we as people experiencing the services that these systems have and the funding that these systems provide, that is how we can then continue to grow the power of people. And it's similar with children as well, right? Creating those spaces, as I mentioned before, where these conversations can happen, and not just conversations between community, but conversations between community and these policymakers, right? I've been fortunate enough to be involved with roundtables hosted by Governor Hochul, where she herself has had direct interest in hearing the experiences of teenagers receiving mental health services and how COVID impacted their schooling and their mental health, as well as being involved with our daily advocacy, right? Just hearing the narratives and hearing the lived experiences of parents and youth on the back end of these decisions that policymakers make, but also having discussions with those policymakers and hearing their side of it, right? I think sometimes we forget that people in policy are humans. They also may be peers themselves, right? They may have also been dependent on the system at one point in time. However, because of the way the system is structured, they too have limitations in which they can be strong advocates. So I just wanted to say that so that, you know, we can understand that it's not just one person's fault. It's not just one system to blame. And there is no one right way to empower somebody, right? There can be multiple avenues to make an individual confident enough to want to become an advocate, to have these questions, and to want better for the services and policies that are impacting them directly, but also impacting the generations to follow them.
Thank you.
Yeah,
Jamila,
I know we're out of time,
Yep.
but I just 30 seconds want to say, you know, as someone who like actually studies power and how it's built and how it's generated, I just want to flag a comment in the chat that talks about building collective power through organizing. And I want to say that there is a path. There is a path. And it's tempting to be like, people who are living in poverty have too much going on. They're not going to be able to plug into this. They're not going to know what to do, and so on and so forth. And certainly for some subset of people, that's true. But I think when we look, for example, at like the ongoing tenant movement and tenant organizing and some of the wins that tenants have been able to get by coming together collectively, yes, the individual empowerment, like Kristin said, but also the strategic collective organizing and working together as a collective. Because if there's something that people living in inner poverty have, it's numbers. There are a lot more of them than the economic elites. And so I just want to say there is actually a path that involves centering and advancing the power of people living in inner poverty. And we're seeing it happen in pockets all over the country. So I think the question isn't about whether it's possible. It may not be likely right now, but it's happening, and there can be more of it happening. So the question is, how can we contribute? Yeah.
How, for sure. Well, thank you all so much for a fantastic and robust conversation. I wish it could go on for another 2 days. Thank you. We really appreciate it. And we invite you all to continue to participate in our panels going forward. Our next one will be in September, and it'll be in person in Albany, moderated by David Lombardo from Capitol Press Room. And we're so excited to have you all and continue to have you going forward. Thank you.
Bye. Bye, everybody.
Thank you, everybody.
Thank you.